Assalamu alaikum. Shukran Abu Rasil. Good afternoon, everyone. Glad to be here again this year. It's always a pleasure to be part of such a scientific conference. Thank you for the invitation from the society. So, updates on large vessel vasculitis. In comparison to ANCA-associated vasculitis and small vessel vasculitis, it is not as exciting. The pace is not as dynamic as small vessel vasculitis, but there are updates which is brewing in the background. So the 8 NTNs are need to knows for those who were asking me from everyone I showed them the slide. So this need to knows are encapsulated into an easy digestible topics. We have 8 of them, hopefully directly impacting your day-to-day clinical practice in managing patients with large vessel vasculitis. So we'll go over them one by one. Approximately half of it is focusing on diagnostics, and then the other half, maybe lesser than half, is on treatment. And we will be starting with the classification criteria. So after a very long wait, 32 years from 1990, finally we had the classification criteria for GCA, giant cell arteritis and Takayasu, published by the American College of Rheumatology and the EULAR in 2022. So the caveat, as always with classification criteria, they're not intended for diagnosis. They're mainly to classify for research purposes. And again, all potential vasculitis mimickers needs to be excluded. So the GCA criteria published with a sensitivity of 87% and specificity of 94.8%. What is interesting to know that in this version of the classification criteria, they incorporated more modern imaging technologies into assessing and classifying these patients. For example, PET scan, an activity PET scan on aortitis has a weight in classifying these patients into the diagnosis. Also, bilateral axillary ultrasound findings is also there. And interestingly, finding of the classical halo sign on ultrasound of the temporal equals in the classification criteria weight to a temporal artery biopsy. Again, greater sensitivity while maintaining similar specificity to 1990. And the age above 50 now is a mandatory criteria to diagnose GCA. Similarly, in Takayasu, sensitivity of 93.8% and a specificity of almost 100%, 99.2%. What is worth mentioning here that the sites of involvement in Takayasu are weighted differently. If you have 3 sites, there are 3-point scores. If you have 2 and you have 1, and as you go. Another probably confusion that might happen with the increased recognition of aortitis presentation in GCA, there is always an overlap. Is it GCA with aortitis or is it Takayasu arthritis, especially if the age is between 50 to 60. So moving into number 2, radiology is taking over. So there is the Spanish registry published in 2022 across 26 hospitals. Where they measured the influence of the EULAR 2018 imaging guidelines. You can see clearly the blue line is the temporal artery biopsy, where it dropped significantly after 2018. And at the same time, we have ultrasound in the red line spiked from almost 29 to 30%, up to 50% of patients who are diagnosed with ultrasound without temporal biopsy. The green line is the PET scan. We see doubling in the PET scan, still not as high as ultrasound, but still from 10% to 20% of patients, PET scan was used to diagnose them in large vessel vasculitis. MRA, MRI, and CT angio are the same. What is interesting, in the ACR 2021 management guidelines, they still prefer temporal artery biopsy and recommend temporal artery biopsy despite having all the emerging imaging technologies. And they referred this to lacking of expertise, for example, and the lack of experience in interpreting this. But also this can be taken in another direction. We can say we need this expertise, so we need to invest more into this, saving patients from temporal artery biopsy and the complications and the limitation of accessibility to histopathological studies that might help in diagnosis. In the EULAR 2023 recommendations, they recommended that the imaging should be done within 72 hours, so only 3 days after starting a glucocorticoid treatment, and it drops the sensitivity of these studies dropped down to only 30% after 10 days. So the recommendation sticked of having the radiological study within only 3 days or 72 hours after starting steroids. So the third one is we need more ultrasound, not only temporal artery ultrasound, but also axillary. So now, including axillary scanning and ultrasound is recommended because it will increase sensitivity. We have 2 studies that are published. The first one is a systemic literature review and meta-analysis, where they published the sensitivity of combining both temporal and axillary to a sensitivity of 88 and a specificity of 96%. Another study published in 2022, where 92 patients with a diagnosis of GCA showed that examining axillary and temporal increased the sensitivity of the studies and the diagnosis by 15%. Moving into the fourth capsule, which is PET scan is emerging. Prospective observation study of 84 patients reported that the clinical disease activity assessment was significantly associated with a PET scan interpretation of disease activity, but not with MRI. So what we need to know that a PET scan better captures inflammation, and MRI or MRA better captures the extent, but not the activation or inflammation that is happening with patients with large vessel vasculitis. An old meta-analysis of 6 studies back in 2011 concluded that sensitivity of PET scan is around 80% and specificity of 89% and negative predictive value of 88%. So this is a case that is following at the vasculitis clinic in King Faisal Specialist Hospital in Riyadh, where PET scan was really important and cardinal in diagnosing and capturing this patient who is just almost 50-year-old female. We can see on the left-hand side in September 2020, where the PET CT showed a very clear enhancement in the ascending and descending, and also the arch with some activity helped us in diagnosing that. After treatment with anti-TNFs, we can see clearly at the same almost level of cut that the inflammation and the enhancement is almost resolved. So not only in diagnosis, but also in follow-up. If you have the standardized PET scan and CT and the radiologists who are familiar in interpreting these and having the right cuts, this is quite important and really helpful. So this is just a recap. I'm sure everyone in the room knows, but it's good to recap what are the differences between ultrasound, CTA, MRA, and PET scan across many dimensions, but we took, for example, operator dependent. We all know that ultrasound is operator dependent. We know that the extent is very limited. You cannot have a full body ultrasound, but there is no radiation. It is quite cheap, accessible, although the accessibility relies and varies by institute. And the time is quite quick. You can get the ultrasound quickly, so it's accessible, and you can get the reading within a few minutes. Where CTA, of course, we all know CTA is full of radiation, and the cost is not as cheap as ultrasound. The same MRA and PET scan, we know that they are not operator dependent, and extent you can have the whole body screening, but again, very expensive, access is not always there, and the time to get the study is quite extensive and it's quite costly. Just going to the last parameter, which is the site. Ultrasound is mainly recommended for cranial, temporal, and also axillary, where CTA will help the extracranial assessment, and it will give us a luminal assessment. MRA will give us the idea of luminal, extraluminal, and the wall itself, so it's quite helpful. PET scan will help recognize any other pathologies and exclude mimickers from the diagnosis of large vessel vasculitis. Going into the treatment part, so we have 3 more capsules. The 6th one is tocilizumab. The famous IATKA trial, published in New England Journal of Medicine in 2017, where 250 patients were randomized into 4 groups. 2 of them are tocilizumab groups. The difference between them that the first group are getting tocilizumab weekly, and the second group was getting tocilizumab every 2 weeks. The other two groups are placebo. The only difference between these third and fourth group, which is the duration of steroids. The primary outcome was the rate of sustained glucocorticoid-free remission at 52 weeks. It is very clear that the two tocilizumab groups had a higher sustained remission with both more than 50% and a significant p-value. Also worth noticing and reported in this trial that the cumulative median prednisone dose over the 52 weeks was 50% less in the tocilizumab group, and the graph explains that. What about tocilizumab in Takayasu arthritis? It is more controversial and more unclear. There are conflicting reports about that. These are two studies published almost in the same period, having two different messages. The first one, where they double-blind randomized controlled trials of only 36 patients, were randomized after prednisone induction to either receive tocilizumab or placebo. And the caveat in the study that the assessment was done purely by clinical, no imaging was involved. And the conclusion was the time to relapse was not statistically different between tocilizumab and placebo, and the graph also explains that. The second one is a retrospective, only 46, again, small number of patients, and they concluded that the event-free survival was significantly better under tocilizumab. So the takeaway from here, tocilizumab in Takayasu arthritis is not very well established. It is left for the clinician and also the patient to decide if other treatments are not suitable, for example, methotrexate or anti-TNFs. Abatacept, this is an interesting approach to patients with GCA, where newly diagnosed and relapsing GCA were recruited and induced with abatacept with 4 doses at day 1, 15, 28, and then at week 8. And then after that, if they achieve remission, which is out of the 49, only 41 achieved remission, they were randomized either to continue on abatacept or to discontinue. We can see clearly at the bottom side that the 20 patients on abatacept, almost 48% achieved the primary endpoint and were relapse-free, and the placebo group had around 30% achieved. So the p-value is barely there. It is 0.049. So if you round it up, it is 0.05. So the conclusion from here that abatacept is an option, but definitely not the first or second options in treating patients with GCA. Finally, definitely last, but definitely not least, our beloved steroids. So the ACR recommendation clearly recommended that for cranial or ischemic manifestations, intravenous glucocorticoid induction is recommended. If there is no extracranial, no ophthalmological involvement, so just oral steroids is enough. So in this very old study in 2006, it's interesting to see that 27 patients were randomized into 2 groups, either receive IV methylpred for 3 days or placebo, and then continued on oral. And the primary outcome, number of patients at 36 and 52 weeks who achieved prednisone dose less than 5 milligrams. It is very clear if the patient receives IV in the beginning, it will help him and help the patient taper prednisone to below 5 milligrams at 36 and 52 weeks. And also worth mentioning that the cumulative dose is much less if you receive at the beginning the IV methylpred on the first 3 days. So to conclude, classification criteria are for the purpose of studies only, and it is incorporating mainly more imaging techniques. Second, radiology and diagnostic tools are increasingly utilized and recognized as a tool for diagnosis and classification of large vessel vasculitis. Third one, auxiliary in addition to temporal, will increase the sensitivity of your ultrasound studies. 4, PET scan can capture inflammatory activity, while MRI only is better for assessing the disease extent. And the 5th, with the comparison between all the imaging modalities we have. Number 6, tocilizumab is a recommended option for GCA, still controversial and not very well established for Takayasu arthritis. 7th, abatacept might be an option for GCA. And the final, IV methylpred for cranial ischemic involvement and oral for non-cranial. Thank you very much.